Hello, everyone, and welcome to this Lunch and Learn session with the Healthcare Project and Change Association. I'm Jo Stanford, I head up the HPCA, and I'll just give you a very quick update on what's coming up and what's available as part of the community. And then we'll get into the hot topic of the moment, pretty much anywhere in the healthcare sector, which is around the Ambient Voice Technology rollout across the UK. And I'll be introducing today's speakers as part of that. So just while we get others in, I'll just give a very quick update. This is your opportunity to ask the questions, to make comments, to share your thoughts. So if you can start me out by introducing yourselves in the chat, these events are always fantastic for networking and connecting. So please do say who you are, where you work, what you do. And if you're happy to share your LinkedIn and make connections that way, please do that. And if you see people you know, give them some love. If you see people that do similar kinds of things to you, give them a thumbs up and see if you can connect with them. So while you're doing that, I'll just give you a very quick update. Hi, Carl, lovely to see you. If anybody else would like to stick their camera on, it's lovely to see people. Please do. I appreciate it's lunchtime. If you're eating your lunch, you are excused. So HPCA is a not-for-profit community interest company supporting the development of project and change capability and workforce across the UK. This is open to anybody to be part of the community, and we have regional networks in Wales, Scotland, Northern Ireland, and across the regions in England. I'll tell you a little bit more about the events coming up in a moment. We're also here to support the professionalisation of project management and the raise awareness of what we can do collectively to support the delivery of some of these really key priorities that are coming up at the moment. So in terms of what's coming up next, we have today's event, and then we've got some storytelling events that are coming up with Bryn Hodgkiss. If you've not been to those, please do. As a project professional or change professional, stories are at the heart of how we convince other people to go on the journey with us, and building those skills is going to be important when AI takes over some of the more technical elements of project management that we used to spend most of our time doing. So think about what we can do in that space and how we influence others. Come along to those events. We've also got one on the Connected Care programme with Tara Marshall. Again, this is more about use of technology in service delivery and lessons from that. So please do come along to that one at the end of June. Regional networks. We have some regional network dates coming up. The North East, London, Wales and South East are all in plan. We've got some other dates that are in the schedule, so do look on our events page to get registered. And we're very excited to say we've got a new Northern Ireland regional community that we're going to be kicking off very soon. So please do keep an eye out for those. You're welcome to go to any network that you want, but it's also an opportunity to meet people around your region, get to know them, connect and build relationships. We deliver training to support capability development. So we have a series of level 2 programs on project management, benefits management, change management, risk management, and the SRO role. So please do sign up for those if you're interested, or get in touch. We also have quite a bit of specialist training around change management, because people are ultimately at the heart of most of what we do across the health and care sector. And it's a big area that we could look to improve on. So if you're interested, do get in touch around those too. And then there's more about Bryn's storytelling, and it does workshops and masterclasses for organisations and teams wanting to build those skills. If anybody is affected by the changes that are going on personally and people in their team, and I'm mindful this is going on at every level at the moment, we do have a series of resources and events that we have had that you can watch that will help you navigate some of those challenges of the changes that are taking place, but also to help to support your colleagues and team members. So do look on the website in the Change Under Pressure area for support for you and your teams. We have some client-only events. We had one just earlier today, and we've got some coming up soon around understanding neuroscience for leading change and introduction to project planning. So if you're interested in those, maybe convince your organisation to get membership, and then you can access some of these great events and training. Membership covers all sorts of resources and will help you and your organisation get standards, consistency in place and build capability. So that's my pitch. I'm going to stop now and hand you over to the reason why you're here today, and that is to hear more about the fantastic work that's been going on around piloting ambient voice technology from Megan Morris-Carter, and hopefully Ed will be joining us shortly if he's not here already. And if you have any questions, hi Ed, fantastic. Phew, good to see you. That's great. And Ed. So I'm going to hand over to Megan, who's going to start us off on the topic. And thank you from you and colleagues from Oxford University Hospitals coming to share this pilot with us. And for those that are going to be starting off that journey very soon, questions in the chat or in the Q&A. We'll make sure we've got time to answer them at the end. Okay, Megan, thank you very much for joining us today. Over to you.
Super. Yeah, thank you so much for having us. Really interesting to talk to you all, and I think to hopefully just sort of discuss what we've learned and get your thoughts on where we go next, because we're definitely on this journey. We're definitely not at the end yet, and I'm sure there'll be lots of discussion about how best to approach this in trusts across the country. So what we're going to do today is we're going to talk a bit about ambient voice technology, and specifically we ran a pilot program last year, and we are now in the middle of a procurement exercise, so almost completed the procurement exercise, and we're just spinning up an implementation project to roll out ambient voice technology across a large majority of our services. And we're going to talk to you a little bit about that pilot, what we learned from it, and what that therefore has enabled us to do in terms of project planning for the implementation. As Joe has said, we will definitely leave some time for sort of questions and comments and discussion at the end. Do feel free to put comments in the chat. However, I will say that given the sort of screen sharing arrangements, I might struggle to see those during the session. And so I do apologise if we don't sort of pick them up straight away, but we will definitely come to them at the end.
I'll keep an eye out, Megan, and capture any key points along the way to share with you. Thank you.
That would be super, Joe. Thanks so much. So hopefully you can see that the slide has moved on. Do wave if it hasn't. So the pilot that we did last year was between April and July. It was very much a functionality-led pilot, so we didn't integrate into the electronic patient record, but it allowed us to test solutions from both startup companies and quite small companies and larger organisations. And the reason for this was that we see this marketplace as being quite an interesting one, in that there are some of the larger providers, some of the EPR providers even, developing their own ambient voice technologies, but there are also a lot of new entrants into the market, and some of whom have specialised in ambient voice technology. Now, this technology, for those that aren't familiar with it, is ambient scribing. So it's essentially an AI listening into a conversation between a clinician and a patient, and then creating a meeting note, so a clinical note that can go into the EPR, and then also creating a clinic letter, so a letter to a patient or a letter to a GP or onward referral, whatever it might be. And so quite a specialist piece of kit that has built upon what's, a relatively new piece of technology. And what we really wanted to understand was, how do we need to approach procuring something like this? Is it going to do anything for us? Because, sometimes systems that seem to offer benefits in terms of efficiency and the like don't actually offer those benefits that when you test them. And also, what should we be asking people when we think about procuring something, and what might we want to think about for implementation? And so we'll share some of those insights with you today. We tested 4 providers, a couple of, as I say, smaller companies, a couple of larger ones, across 5 different departments. We split them into simple and complex use cases, and Ed will share later some of the things we learned about how well it works in those different use cases. But essentially the difference between those was around the level of complexity of the dialogue and the number of people involved, and what exactly was going on in the room at the time. And the aim was to test the usability and functionality, but also look at the variation across providers and what use cases we might have for the technology within our hospital. So we had 160 users in total, over 9,000 encounters, and nearly 200,000 minutes of transcription as part of that pilot, and produced 6,500 letters and clinic appointment notes. So quite an extensive test that allowed us to really learn how we should move forward with this. So in terms of expected benefits, we expected some time savings from what we'd seen from other people, and a potential impact therefore on productivity, but also on stress and workplace well-being. We had seen some of the results of sort of quite small studies in other places, but we hadn't seen a large-scale study like this as of yet at the time. Now we've also got the results of the London study, which has been quite helpful in understanding kind of where the return on investment might come from. And actually we saw those benefits. So we saw quite consistent benefits in simple outpatient settings, including the reliable time savings. There was an average of 10 minutes time saved per encounter, which is averaged across all encounters. So those that saved nothing and those that saved a lot more time as well. There was a marked reduction in cognitive load. So staff were saying they were less stressed, that they were more able to concentrate on the patient, that they felt less overwhelmed with detail. And that was particularly the case for staff where English wasn't their first language, so they weren't having to kind of struggle with the grammar and kind of structuring their note. Instead, they got a draft, which they then could edit. And there was a real positive impact on staff who reported working lots of hours in evenings and weekends, catching up on their letters from the clinic. And there was a marked reduction in that sort of in that time that was spent. I'm now going to hand over to Ed to talk in a little bit more detail about some of these findings and some of the things that perhaps we didn't expect to see, but we did see within the pilot. So Ed, over to you.
Thanks, Megan. Yeah, so time saving and reduction in admin burden around the creation of documentation really was what we most expected to see. We'd had some users informally using AVT solutions in their private practice in the trust, and we spoke to a lot of people ahead of the pilot to understand what knowledge and insights they already had. Lots of people had encountered it through general practice as well, through either being a patient in general practice or having colleagues using it in general practice, where it's a lot more widespread than it is in the acute sector currently. I won't dwell on these graphs too much. I think we're going to share the presentation, and you're very welcome to kind of read our full report as well, which sets out some of the detail of the time savings. But essentially, we saw a lot of this coming through, that very few people didn't experience any time saving, and the time saving that people experienced kind of depended on the use case, depended on the kind of workflows that they were introducing AVT into. So, giving an example of some of the range of use cases we had some very kind of standard, very low complexity appointments in places like endocrinology, where there was a relatively small time saving because the letters typically didn't take a huge amount of time for those clinicians to complete. They were quite straightforward, practical records of the conversation. There was rarely any complexity to follow up in the creation of the letter or the note. Nonetheless, those people still felt a huge admin release, particularly when they'd had a busy clinic day and were able to get all the letters done before going home. And then there was some at the other end of the spectrum, for example, community pediatrics, where our consultants are seeing patients and indeed their families, and often people from other agencies in the same room, an hour-long appointment with a huge amount of documentation to review and preparation, and then a very long and complex note and letter generated at the other end, where the time savings were much more significant. So the amount of time saved really depends on the workflow, as you can probably imagine. But there was no, I think there was probably one person that I heard from who felt frustrated that it hadn't delivered the time savings that they had expected. And actually, having caught up with that person's department since, having spent longer working with AVT, they now have achieved those time savings. So it really does deliver in this respect. And if we just move through these slides, Megan, that's great. So again, there you can see the difference pre and post AVT. I think this isn't this isn't kind of like for like, so this isn't the same people spending the same amount of time, but you can see what we've done is we've moved that curve away from those kind of significant amounts of out of hours working. And that's one of the big things, as Megan mentioned, is the transformative impact on people's work-life balance is hard to overstate here. People telling us that they had been working every Sunday for the last several years just to get their documentation finished in their own time, and that they now had their Sundays back. Or that people had routinely stayed an extra 2-3 hours after every clinic day in their department to finish off their letters, that were now able to leave work on time. Really extraordinary. And that's important for us to bear in mind. We're going to come on to ROI later, return on investment, and cash releasing benefit and bottom line benefits, those kind of things. But we can't overstate how positive people felt about the impact this had on their experience of work. And interesting, one of the things that we want to track is how is it sustained? So I'm sure everyone's familiar with that. All the research out there that says that when you win the lottery, your happiness and well-being spikes and you feel on top of the world. But all the research suggests that within 6 months or a year, people are back at a baseline of their general contentment and happiness. I've been a little bit concerned we might see something similar here. People feel the benefit of the time pressure being released, and then just more stuff comes in to fill that gap, and they feel just as overwhelmed as they were before. But having kind of stayed in touch with some of these departments that have been using AVT, actually there's a culture change that's engendered there. So people go from sort of surviving and just getting through the day to being able to do more meaningful and fulfilling work, and that benefit feels like it's sustained. Like, we haven't said anyone say, oh well, it's just gradually the benefit has worn off. So these are the secondary benefits, I suppose, we're talking about that stem from that time saving. So improvement in well-being, reduced stress and lower mental health, fatigue, all of those things. We tracked very similar questions to the staff survey questions and saw it deliver on those very significantly. A lot of people talking about their approach to the day. So rather than coming into a very busy day with a sense of dread, they felt like metaphorically they could roll their sleeves up and just get on with the busy day and then leave at the end, put their coat on and leave it behind, rather than having the burden of the letters hanging over them. We didn't do direct patient surveying in our project. We didn't have the capacity to do that, but we've had a lot of feedback from clinicians secondarily reporting their experience and the reactions they received from patients, and the quality of presence and focus in the meeting, even from people who said to us, I always thought I had pretty good communication skills. I think I always thought I gave my patients a really good experience of being in the room with me, and I didn't think this would really make such a difference, but it has. So lots of people were telling us that the experience of being able to sit down and really pay attention to their patient, not need to turn to the computer and make notes, and to really spend that quality moment with them was significant, and they felt that the patients really responded well to that. And we'll be looking at doing direct patient surveying when we kind of go into our deployment. And yeah, some of the kind of knock-on benefits from the automation of the letter writing as well. There was the time to letter production was affected. Obviously, people aren't having to kind of carry their letters over for a couple of days until they find they've got an admin slot, or indeed an evening at home where they can do it. It means letters get out more promptly, and they also kind of talked about the quality of the record being better. So there's an instantaneous or near instantaneous entry into the medico legal record, and it's high quality objective content as well. So coming back to this comment from a specialist nurse, it sums up some of the things that I talked about there. So that focus, the quality of interactions, people appreciating the conversation, details that the practitioner was interested to see that the AVT captured, so softly spoken individuals, or where the conversation might have been quite fragmented, that it captured those things very well. And this point we heard from a lot of people independently was that, particularly for so many of our colleagues who are working in an additional language, and I'm always super impressed by people who are running complex clinics in maybe their third or fourth language, no matter how good those clinicians are and how brilliant their English is, at the end of a busy day, it's just another thing to have to think about creating a well-structured, carefully worded, nuanced, sensitive letter in an additional language. If the AVT has basically done that for them and they're editing that letter, it's so much easier for them. So in terms of where AVT performed best, as you may well know, AVT is really built for a very standardized consultation environment, and I think this is why we've seen it succeed so much in general practice. AVT loves a 20-minute conversation with a clear structure that's clearly on medical content. So anything that we are doing in the hospitals that is close to that, that is, you know, two people, a patient and a practitioner, or a service user and a practitioner, or clinician, having a conversation about quite a defined clinical topic, and then being asked to produce essentially a summary of that in note or letter form, which has quite a clear structure again. So AVT needs templates to turn the raw data of all the things it hears into the outputs you want. So the clearer your template and the more standardized your template of what you're asking AVT to do with that raw content, the better it'll work. So some of the areas we saw success here was the ENT outpatients, particularly audiologists we were working with, and in our diabetes and endocrinology centre, OCDEM, again, where we had very kind of bounded, very kind of homogeneous sort of appointment types and document types. It worked very well. Where it struggles more is where we have higher complexity, both in terms of the content and in terms of the kind of the activity that it's being deployed into. So we tried it in our critical care unit, so in our ICU. We knew that would be an edge case, and we wanted to include scenarios where the AVT was really stretched beyond its core capabilities, and our intensivists were aware of that's what we were doing, so they didn't expect great results, and that we gave it a really good run out, and we were really interested in what we learned. So some of the things that were a challenge there was you had you know, maybe 6 or 7 up to a dozen people around the patient's bed in the bay, highly variable conversations. As you can imagine, in critical care there can be any number of reasons why someone is in one of those beds, and it's different from bay to bay. Sometimes trouble hearing all those people in both in a kind of spread out grouping of people around a bed, and also in an environment where there's a lot of emphasis on keeping volume levels low and kind of very calm and orderly way of talking. So literally the microphones being too far from people, so we had to kind of find ways of working around that with lapel mics, things like that. But another challenge with that was the amount of data that had to be fitted into kind of very specific forms on the EPR that we use in critical care. So AVT loves, in most cases, creating a single letter or a single note, which we'll then put into whichever kind of management system, whether that's the EPR or whether it's a content management system of some other sort. Whereas if you're populating lots of little fields of data, that's an output that AVT is less kind of well set up for. So struggled there. Struggled in things like some environments with more psychosocial history taking, where the salience of clinical information is harder sometimes for it to extract. Now these models are getting better all the time, and actually it performed very well, but we found that where there's kind of much more structured medicalized conversation, that it performs better than when it's trying to differentiate the nuance of, for example, some family history or some emotional experience that is relevant to the case, but can come across like the kind of chit-chat background noise that AVT will routinely try and screen out in other scenarios. Having said that, where it's been used for longer, I mentioned community pediatrics earlier on, and community pediatrics is really one of those examples where there's very, very high complexity and a very kind of, it can be very unstandardized, the things that come up in the room, also very often chaotic environments where you might have a child with very pronounced disabilities and behavioral needs with their parents, possibly another child, possibly a support worker in the room, multiple medical professionals coming in and out of the 1 hour consultation, lots of different inputs and voices, and then a very complex letter that could cover any number of topics coming out the other end. Community pediatrics have continued working with AVT and have continued to find an incredible benefit of a 75% drop in the amount of time they're spending documenting letters, and all that time has gone into changing the culture, so it's now a culture of improvement, and they're doing great work there. So I would say it struggles in high complexity environments, but it still delivers really significant benefits.
Thanks very much, Ed. So thinking about why this pilot was so successful and actually people still want to use the technology, I think there were a number of different factors that helped us to get people on board to actually give us the information we needed to be able to create the report and be able to report back on all these aspects of the benefits. The first one was that the really early co-design with departments. So Ed and his colleague Ravi went into each department, very much worked with them to think about how this might work with their workflows, and did an excellent job of making sure that there was an iteration on templates, that there was an iteration on workflow, that there was a real champion there within the department supporting the clinical staff, and sort of really trying to push the boundaries of what the technology could do. I think the other piece that was very unusual with this particular piece of technology, I'm sure we've all experienced technologies that benefit one group of people within a hospital or a care setting, but it's another group of people who have to use it. The classic examples being things like EPRs and kind of data collection tools and things like that, where quite often the institution needs that information, but the person who's inputting it just sees it as an extra admin burden. This was very different to that. There was really good top-down support. You will have heard government talking about the benefits of AVT and how they want it rolled out. There was top-down support from our institution as well, and there was also real ownership from staff on the floor and clinicians who really wanted to use this technology and felt it was going to benefit them personally, which really gave a lot more buy-in at all levels of the organisation. There was also really good alignment with organisational psychology. So it was actually pretty easy to use the technology. There was a relatively low activation energy, and really visible value came back very quickly for the individuals who were doing it. And although there were one or two who sort of said, and then do I have to fill out your data form, when it was explained to them that really this data is going to then lead to us being able to do a business case and a procurement, there was really good buy-in from everyone. There was minimal training required on the software. It's actually very easy to pick up. And we made a real emphasis on staff wellbeing benefits. So not pushing this as a means to see more patients, even though that could be an outcome in the longer term. We'll talk about that in a moment. But pushing it as a benefit to staff and something that they might find allows them to operate at top of license, to do the work that they were trained to do and that they really want to do, and to do less administration, which is perhaps the thing that they don't enjoy so much. The pilot helped us to then shape a procurement, and it was really, really helpful to have interacted with so many different suppliers and to have understood a bit about what the landscape looked like, because I think it one of the things, for example, that it really enabled us to think about was that an open procurement was appropriate, because actually all the suppliers did pretty well, and all the suppliers were relatively much of a muchness in terms of the quality of what they were producing. There were a couple that fell out at the beginning that couldn't produce what we wanted, but of the ones we tested, they were all pretty similar in quality, and that gave us the confidence to go out to market with an open procurement, because we felt that there were a number of different suppliers out there who could do this job, and therefore it was appropriate to try and get best value for money. Some of the things we had to think about really carefully, and Ed's touched upon return on investment. We had to create a business case in order to be able to move forward with procuring the technology. The business case actually rests upon removing other tools that we currently use for dictation, and having communicated with the wider Innovation Exchange, which is a group of innovation teams across different acute trusts in the UK. We sort of compared notes with a number of other trusts, and actually that's a very common route for this, because it is essentially saying, look, we're saving some cash by not paying for these other dictation tools, and then we're going to spend that on the ambient voice technology, which does dictation, but also does that synthesis into a note and into a patient letter that is one step further on than the pure dictation. Actually, of course, our institution would also like to see some return on investment for that time saved. And so one of the things we're having to look at now as part of the procurement and then the implementation is, how do we actually look at, okay, if we're saving 10 minutes per consultation, what does that 10 minutes get used for, and how do we structure the workflow so that either more patients can be seen, or there can be other things done like quality improvement projects or advice and guidance, or other activities that are of value to the institution so that they can see that return on investment. we already see there's a return for the individual using the tool, but we have to also try and balance that with the needs of the organisation. And that's going to be an interesting conversation, I think, as we move forward into implementation. Other elements of the procurement. So we looked at EPR integration. This would clearly be a positive, and we've asked all of our suppliers in the procurement to have a roadmap to integration. However, we recognise that if we limited it to only those who can currently integrate, we would not necessarily be getting the best tools for the job. And we got a very clear steer from our clinical workforce that what they want is something that's really good. They don't want to be fobbed off by something that isn't as good, even if it integrates with EPR. So we had to kind of design that part of the procurement very carefully. We had to think about templates, and this is something that will come onto with the implementation as well. And make sure that there was a bit of flexibility there, because different clinical teams work in different ways. We had to think about accuracy, workflow fit, reliability, so all of that functionality piece, and make sure that it really delivers for the person who's using it. And the reason for that is that we recognised that during the pilot that where we had started with a tool that didn't work very well, actually it was almost impossible to get the clinical team to work with us on the pilot, and we just had to drop it. And therefore we didn't want to have that same issue when we're thinking about implementation, and we didn't want to be giving people a tool that's just going to make them more frustrated when they're so excited about getting something that will really reduce that admin burden. We also had to think about some of the technicalities around data and governance, particularly this being an AI technology, but also that some of the suppliers are located in other countries or have data centers in other countries, and how does that play with where we would like our data to be stored. Also thinking then about kind of how well can they support us, particularly if they're somewhere else. Can they provide the user support and the scale that we needed as a large institution, because we were working with both small and large companies, and we absolutely want to make sure that both companies at all parts of the spectrum are able to work with us as an institution. We nevertheless had to kind of be quite careful about defining how much support we need to roll this out, because otherwise I think there's a lot of burden on internal teams to make something happen. So I'll finish by just giving some recommendations for a successful implementation, and perhaps talking a little bit about kind of what we're doing now to set up the project, and then we'll open for some questions, and there'll doubtless be a bit more discussion, and I'm sure Ed will come in with some comments as well. So what we're doing at the moment is we've set up a project team, we've defined our work streams, and we're starting to plan the project and do some pre-work to be able to get to the place that we need to be by the time the supplier is selected. And actually, the procurement is taking quite a long time, but it's been quite helpful to us as a project team, because as I'm sure you appreciate, it's really helpful to spend a lot of time in planning, so that when you get to the point of handing out licenses, you've got all the questions answered and you know where you are. The first thing we've been doing is looking at prioritisation of departments for licenses. We have gone with an approach of doing a department by department rollout, so not individual licenses to early users, but rather sort of giving licenses to a whole department, then looking at how that changes the operations of the department. The reason for that is really to drive that return on investment, and to make sure that for example, if they think they can see another patient in a clinic, that the clinic template can be changed, and it can be changed for everyone, not just for one individual. So doing it department by department. This has got quite good evidence as well from our pilots and also others that we've seen, that people, when using quite new technology like this, get a lot of support from each other, and so doing them as a working group is quite a helpful thing to do. But the other thing we've had to think about, and we've had to sort of work with our divisional teams to decide upon, is where are the high yield settings? Where are we going to get that return on investment that justifies our business case, so that we can then get more licenses and roll out to the rest of the institution? We're very much co-designing with local teams, talking to them about how this will fit with their processes, what they think the benefits might be, how those might be realised, what the steps are going to be to be able to realise those benefits. And part of that is building templates. and in particular having some high-level conversations across the institution about what's our strategy for templates. Is everyone just allowed to create their own? Do we want to limit the number of templates? And how do we manage that trade-off between, if there are lots and lots of templates, that's lots of different individual things to manage, and it might get a bit unwieldy in terms of the number of different things that are happening, versus actually some tailoring of the template gives you a better result because the AI is better at delivering the result you want if it's got the right template. So we're looking at a model where there are probably, you know, sort of 2 to 4 templates per department, and the clinicians in that department will input into those templates, and then there might be a little bit of flexibility for individuals to play around with the templates and sort of customize them for themselves, but also a feedback mechanism so that if someone changes a template and gets a really great result, let's feed that back into the standard template. Because one of the things we recognise is that some clinicians will fiddle with this and adapt it to their own uses. A lot of people will use the standard template. So we need to make sure the standard template is as good as it possibly can be for that department. We obviously need to support safe and efficient use. So we need to make sure that people are well trained and that we've got all the governance in place. We need to be quite transparent about what we're trying to achieve with the project. And I think those difficult conversations about, yes, this is going to be great for staff well-being. It's going to be great to reduce the admin burden, to allow you to see more patients and to do the job that you really want to be doing. But also, yes, the institution is looking for that, some of that efficiency to come back in the form of more patients seen or lower waiting lists or other jobs done that need to get done. And then finally, a continual iteration of evaluation and improvement to try and, you know, although we're not officially in a pilot now, we're in an implementation next, then I think it will still be a bit of a pilot for the first few departments as we learn what works and we try and drive that benefit for everyone concerned. So I think I'll pause there. I'll just leave this slide up for a few minutes just so that you can see the contact details and feel free to sort of grab those. The slides will also be shared afterwards as well. So if you want to contact either myself or Ed, you're very welcome to. But perhaps we'll now sort of open it up for questions or comments and have a look, see whether there's stuff come up in the chat as well.
Thank you, Megan and Ed. That was fantastic. Really valuable insights. We have lots of questions, which is fantastic. I'm going to give precedence to the hand that's up. So I'll take it in turn. So if you also want to ask a direct question, stick your hand up. We'll do them in order. David, if you want to go first.
Yeah, hi. Yeah, I'm Senior Project Manager from Frimley Trust. So just interested, can you just elaborate on the timeline you worked to in terms of, you said you started in 25 and we're now in 26. How long did it take you to design the pilot, run the pilot, and then move through to the procurement stage, please?
Yeah, so really interesting question. This was actually a pretty rapid turnover compared to, or turnaround compared to what we would normally do in this space. So we first started talking about AI tools and the need for an AI policy in the trust probably in sort of December 24 into January 25. And then by kind of March 25, we had decided that AVT was going to be really important to us and we needed to do a pilot. The team put together that pilot really, really quickly in sort of March and April 2025. And then we've sort of ran it over the summer with a little bit of a hiatus in August because a couple of the departments were not really able to engage during August because of holidays and things like that. By October, we had got interim results from the pilot and we were already putting together the business case. So the business case got signed off in October last year. But then we didn't start the procurement process until December because we needed to wait for the final results of the pilot and check that, you know, the results were still consistent from that interim period. And then, unfortunately, although we set up the procurement in December, it didn't actually go live until earlier this year, and we've now been in the process for 2.5 months, I want to say, and it's dragging on a little bit, I have to confess, just because of people's availability and time, and that we wanted to make sure we had the right people making the evaluation because we wanted to get the buy-in across the institution. But that means then that you've got to get in their diaries, and that's been really challenging.
Thank you.
Does anybody else have any questions they would like to ask directly while you're thinking about it? I will go through some of the ones that are in the chat. Excuse me, lots of questions in the chat. Oh, Lee Rucker, do you want to come in? Hi, Lee.
Hi, how you doing? Yes, I wanted to just ask, like, now I mean, it's amazing that you've had such a really good focus on staff and well-being and what it can give back. As you're moving now into that sort of formal business case, are you seeing kind of additional pressures to give, you know, a productivity gain? Because you mentioned sort of working department by department, but are you seeing those kind of like, right, our new standard operating procedure is that you need to almost like gain share and you've got to see an extra appointment a day or 2 appointments a day? Are you seeing if that coming in to stack up for the financial business case?
Yeah, so really interesting question, Lee. And yes, absolutely. I think it's a really delicate balance, isn't it? Because I think, you know, our pilot very conclusively showed there were lots and lots of non-financial benefits to the technology, and I'm sure you're seeing this across the country as well. I think nevertheless, all of our divisions and all of our departments are under pressure to do more with less. Some of them, you know, are already in an unsustainable situation, and this might kind of just make it sustainable for them. For others, this might be the catalyst to help them see that extra patient in a clinic, or kind of do a bit more with the time they've got. So absolutely, we are seeing that pressure. You know, our CFO is obviously very keen to see that the money is being well spent, and I think that's consistent with the national picture as well. I think probably what we've concluded is that there will be some departments for whom there is definitely an ROI, a financial ROI. You know, we've definitely talked to clinicians who've said, yes, I could see extra patients if I had this tool and it was working for me. There are also other departments who say, well, hang on a minute, I'm already doing 5 to 10 hours of work on a Sunday afternoon already. This might get me some of those hours back, but are you seriously telling me I should see more patients with them? Perfectly reasonably, you know, they're already overstretched, they're already, you know, and maxed out. And I think that's the thing that's going to be really difficult to untangle, is that actually that is still an ROI, because those people are going to fall over eventually if they don't get some relief. You know, there's going to be, I noticed in the chat there was a comment about sickness and sickness rates and kind of, you know, people going off on stress and things like that. I think, you know, there undoubtedly is going to be an impact on that. And if you make people's lives easier and you make it, you know, easier for them to do those things. But it's much harder to put that in the business case for this year as a genuine productivity saving. So we're sort of doing a combination of both, really, trying to find those departments where there genuinely is some cash that we can give to the institution as a return, but then also recognizing that there are departments who really need it for other reasons and where there will be non-tangible benefits.
Yeah, I don't know if this is a good time to bring in my flow chart, which I'm proud of, but but there is quite a kind of clear way to work through those questions department by department. It's worth saying as well that we are saving a significant amount of money by divesting from the dictation solutions that we've got in place, and it does a much, you know, pretty much everyone who has used our dictation software and then tried AVT has commented on how much better the AVT is because of how the technology is set up. But it's not quite enough. We're not saving quite enough money by kind of shifting that budget across to AVT. So we don't need every department that wants AVT to demonstrate that financial ROI. We, you know, at the moment, the understanding we have is if we can demonstrate enough of that to top up the money essentially that we're saving by divesting from the dictation, then that's what we're looking for. But that may change. We know kind of how tough the financial situation is at current, and it might not get any easier. But if I just quickly share, because this speaks to, I think, some of the points that we're just talking about. Is that sharing now?
That's sharing, yeah.
Great.
Yeah.
So the first consideration is really about time saving. So, but you know, that time saving both through the reduction in documentation, maybe the introduction of a dictation tool that actually works. The second is, can that time be, decision two is, can it be converted into more clinical activity? Is there an unmet demand that one can actually pull in to that increased capacity? Is the activity payable? So some departments may already be close to the cap of what they can charge for on their tariff. Is it within contract, that kind of thing? And will that increased activity be recorded, coded, and counted? If not, the activity could still be financially defensible. So, for example, if you're making the argument that there will be general productivity because people in their admin time will be able to answer emails quicker, get involved with quality improvement work, be better line managers, take less time off, that kind of thing. You can make your financial case around that, but it's not an ROI, cash ROI enhancement that you can demonstrate. So that's outcome A, financially defensible, but a cost avoidance benefit rather than kind of cash ROI. So moving down the decision tree, is there support to realize the income? So if we can create more clinical activity, so for example, there are first appointments in outpatients that we could increase, is there support to realize that income? So that could be a number of things. It could be support in the sense of, is there consensus among the staff group that they're able to do that, rather than the scenario that Megan just suggested, where people are so overwhelmed that you're basically throwing them a lifeline, versus departments where people are saying, yeah, actually, I got into this job to see patients and not to write letters, so I'd very happily change my job plan so that I was spending two hours a week more seeing patients. Or, yeah, this clinic, we save enough time in clinic to add another clinic within the clinic hours we already have. So if there's that support in the broader sense to do it, then that gives us direct outcome B here, which is a genuine income generating ROI. And even if that's not the case, is there cost avoidance? So when we're talking about time saving, or if we're talking about morale and well-being, for example, if we've got a department that has a particularly high use of locums or bank staff because so many people are burnt out with stress, again, that's an ROI you can see if you can evidence, and it's not easy to evidence this, as we've realised at TheHill, working on other stuff that has a value proposition very much around well-being. It can be very hard to evidence that your intervention is the thing that has stopped people taking time off sick. But nonetheless, that is potentially, if you reduce the locum spend, that's a very good proxy for that well-being and work-life balance converting into a bottom line benefit. And all the other kind of things, if they come back to a no, basically take us to outcome C, which is, yes, improvement in people's quality of experience, documentation, improvement, safety, all that kind of stuff. So again, another really important set of improvement benefits, but not that kind of genuine ROI evidence. So that's kind of the conversations, and many of our, particularly our operational leads in our divisions and directorates, are already thinking in that way. So this flowchart is in some respects teaching them to suck eggs, but it sets out nice and clearly the kind of the decision making you can go through when you're looking at a department and trying to work out which ones deliver ROI. And we do have confidence that we will find enough of those to, across the piece, satisfy the need for kind of this thing to pay for itself, really.
Yeah, no, that's really excellent. I think it's a great piece of work. Thanks for sharing both. Thank you.
That's great. Thank you. Thanks for those questions, Lee. We've got Mark Kendall. Do you want to ask your question, Mark?
Yes, thanks very much. I'm from Digital Health and Care in Northern Ireland. I suppose specifically we have a couple of questions. Just one would be around public engagement with, first of all, your patient cohort and how you dealt with that. And secondly, probably your staff side from your medical secretaries and the admin, and the impact this will potentially have on your resources within your medical secretary pools, and what this means from I suppose from a delivery perspective of those admin functions that will obviously have a reduction in what their job role is really as part of technology.
Did you want to pick up that first one first, Ed?
Yes. So in OUH, in our trust, there's only a minority of clinicians who don't write their own letters, don't generate their own letters. So there are very few departments where we have secretaries or admin staff creating the letter. So there's a minority of cases where administrators get quite involved with the letter production. And actually there we've had very positive feedback. I can imagine there might be other organizations that work slightly differently where there might be concern, and this is always the case with bringing in AI, that people have that feeling that is it coming from my job? So I think there will always be it needs to be a lot of reassurance, but authentic reassurance that the aim isn't to kind of reduce the headcount, and that's something that we always think about very carefully with AI projects.
Yeah, in terms of the sort of patient engagement, so within the pilot, we didn't talk to patients directly. We just didn't have the level of resource to do it because we were sort of, very much doing it in-house with the people we had. But we did sort of ask our clinicians to talk to their patients about kind of, how they found it. And we also got the clinicians to consent the patients verbally at the beginning of each consultation. And it was very interesting to note that of all the consultations that were done, only one patient said, no, I don't want you to use this. There were a few more instances of people sort of going, well, I'm not sure about AI, but then saying yes anyway. But only one patient didn't want to use it, and so that gave us the confidence to kind of move forward, thinking, it's not going to be the case that actually we roll out this technology and then half our patients don't want the clinician to use it, and that's going to be a real problem because then the clinician's not going to be getting the benefit and they're going to be having to type the notes anyway, and they might sort of feel that the technology isn't worth it. We have had a bit of patient engagement in the development of the AI policy, and specifically in some of the areas around consenting and, should people be allowed to sort of not consent, and what would be the process if that was the case, and that's fed directly through into the AVT work and the idea that actually we would allow patients to say, no, I don't want you to use this, please could you switch it off, and that we have a process for that. And that's largely because it's such a new area, I think, and because AI is so much in the public consciousness, and it's considered to be, that edge case technology. In 20 years' time, it might just be standard of care, and there might be less worry about it. But I think at the moment it is potentially quite concerning to them. We had lots of staff engagement. A lot of them are very enthusiastic, is probably the summary, the short summary.
Fantastic, thank you. If anybody else has any other questions they'd like to ask out loud, please do put your hand up. But what I will do is dive into some of the questions that were in the chat. It's quite a lot, so I've put it up on another screen to see. So Alison Waller's put, I'd be interested to know what barriers there were that meant direct patient feedback was not gathered during the pilot.
Yeah, so I mean, largely a resource one, to be honest, because we would have had to literally kind of go down there with a tablet and start collecting the patient feedback. We did give the clinicians the opportunity to ask their patients, and also, there was a QR code that they could give for feedback, and no one filled it in. So we kind of had to sort of move on from that. We would quite like to get some more patient feedback as we move into the implementation, but we'll just have to see how it goes in terms of resourcing, because we're also kind of balancing that against can we onboard the next department, in a sense. So there's a balance here between data collection and then kind of using the getting that speed of rollout that we really like as well.
Yeah, and I think OUH, we've got 4 hospitals spread across 2 towns, and we're a team that are usually based off site. So it's not so straightforward for us to go and hang out in departments and do that work. We also, Megan said people did get involved very enthusiastically with the project. We nonetheless had to chase people quite hard to do the granular data capture. So it wasn't, we captured data in lots of different ways and triangulated that data. But one of the things we asked people to do was to, as they used AVT, to regularly complete a form after each consultation, and trying to get people to do that granular data capture was really hard. So my kind of judgment at the end was, I can either really concentrate on getting that data, or I can ask them to spend a lot of their time trying to get their patients to complete a form. And I made the call really that more important at this stage was us to try and make it as easy as possible for the clinicians to give us that granular data on the use of it, and then that we would work more on the patient side when we kind of rolled out.
Yeah, it's worth noting that I had a few interesting conversations with clinicians who were sort of going, oh, why are your team asking me to fill in all these forms? And that there had to be very much that kind of conversation about, well, this data is actually going into a business case, and if you want to keep this technology, you need to give us this data. And it was quite interesting because I think a lot of them also said, actually, you know what, so often we don't get to test the technology before it gets rolled out. We don't get to do the pilot. Instead, we just get given something, and then it turns out to not do what we'd like it to do. So actually, we're really appreciating this opportunity to feed back to you, you know, this is what we want and this is the capability that's important if you're going to procure this. And therefore we're prepared to play ball on filling in these forms, even though you've given us some time back and we'd quite like to use it for something else.
No one wants to do the same 3-minute form 10 times a day. So trying to get even some of that data captured was hard. So
yeah, it really was, but they did a good job.
So just following on from that question, relevantly so, Arlene Morgan has asked, were the 160 users chosen or did they volunteer to take part in the pilot?
It depended on the department. So we reached out to all the different departments. We reached out to loads of different departments, loads of very general engagement work, asked people to kind of ask people if they wanted or their departments wanted to be involved. And we had more departments coming to us saying, please let us be part of the pilot than we could accommodate. And then within each of those departments, we set out saying, well, we want to have 10 core users that we're working really closely with to capture the granular data. So those are people who would have trial licenses and want to understand part of the payoff would be that they had to give us lots of data. Then most of those departments ended up having a whole bunch of other people pitching in wanting trial licenses as well, which was fine. But we were focused on those kind of core users to get the data that we needed. We tried, when we spoke to the champions in each department, we asked them to help identify a diversity of users. So what we didn't want was just a bunch of early adopters. Neither did we want a bunch of technophobes. So we kind of chatted about who in your department might be useful for this. And in each case, it was pretty straightforward. Sometimes the departments were relatively small and didn't have many more than 10 consultants who were doing work that was suitable. But at other times they said, oh, I'll ask so-and-so because actually they're a bit of a Luddite, but are really up for getting involved and always want to help and will embrace it anyway, even if it's not their usual kind of thing. So a mixture, really. We did have a lot of enthusiasm and we weren't short of volunteers, but we tried to be strategic in the kind of people that we asked to take part.
That's great, a good insight. We've only got a couple of minutes left. I'm mindful that there are lots more questions. Megan and Ed, if I send you the list of questions, would you be willing to share some answers to those? And what we can do is then send them out to the attendees. Would that be okay?
Sure.
Could put you on the spot there. But also, I've noted, there are others who are involved in AVT and have also done pilots, and I think there's a lot more learning to potentially be shared. I've offered to say, well, we can pull a community together because we're UK wide, so we've got people from Wales and Northern Ireland, and potentially people from Scotland who might be interested as well, where some of the formal networks and resources might be country specific. There seems to be a bit of an interest in that, but also what we can do is signpost people to where there is relevant guidance and support and things within your own area. If you want to drop links in the chat or send that to us at HPCA, we can help to signpost to what might be available in terms of the support around this particular topic. And if it be helpful, we'll get people together and say, right, what else do we need to learn? Because it's going to be a journey that everybody's going to have to go through. And having gone through the pain of it yourselves, Ed and Megan, and some of the others in the crowd, learning from those lessons and helping others to avoid them, I think would be really beneficial. Mindful we've only got 1 minute left. Sorry, that took up a bit of time. Is there anything else you would like to share with folks? Any sort of last words or comments from you?
I've got one thing, and then Megan, I don't know if you have anything else. I think just one thing you just said there, Joe, going through the pain of it is an interesting phrase, because what we experienced here was something that was very different from that, which is the real pleasure of providing something for people that transformed their experience of work. And for me, doing both watching the data come in, but also doing the semi-structured interviews with individuals afterwards as part of the thematic analysis, having people describe those benefits and those tangible benefits of getting their weekends back, getting their evenings back, spending more time with their family, feeling more fulfilled in their job, feeling like they could leave work at the end of the day tired but satisfied with what they'd done, rather than overwhelmed and dreading the next day when they'd somehow try and fit those letters in. It was a real pleasure. And people telling us, like, this is the first bit of technology that has been introduced that has actually worked. This is, I don't think that's just an OUH issue. I think we do often just kind of foist new stuff on our people, and for them to come back with that positive feedback. So yeah, there was quite a lot of effort involved, but actually there was something incredibly fulfilling about being able to put that in people's hands, and now being able to kind of work on the kind of the full deployment of that technology to more and more of our staff has been really satisfying.
Yeah, I'd absolutely agree with Ed. I think it's a hugely exciting technology, and really exciting to be offering people something that really makes a difference.
Fantastic. And thank you both for your time today. This has been some fantastic insights, some great questions, some others that have some experience to share as well. So hopefully we'll keep this conversation going and help make the most of this opportunity, and support the workforce with things that will actually make their lives easier, get that work-life balance back. Thank you everybody for your questions. We will pass them on to Megan and Ed. Thank you again for joining us today. The recordings will be sent out, a link to it, so if you want to watch it again or didn't see all of it, plus any links to the resources. And thank you to your colleague Ian, who has shared the evaluation report, which we put in the chat, also send out to people as well. Thank you again, everybody. Have a fantastic rest of the day.